Coming up today, a sensitive area, but an important discussion. How to speak up about prostate cancer and maybe even save lives in the process. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Today and throughout the month of September, we want to help break the stigma surrounding prostate cancer and prostate health. Prostate cancer is one of the most common cancers. 1 in 8 American men will get it, according to the American Cancer Society. And the statistics are even worse for Black men. Thankfully, prostate cancer is often slow growing, so if you catch it early, it is survivable. And more awareness has led to more research, which has then led to a range of new treatment options. But prostate cancer and its treatments affect the bladder and the urethra. It can impact sexual function. There are rectal exams, and for those reasons and others, some guys simply just don't like talking about it. But speaking up has the power to save a life. And today we are talking with a survivor that has no problem, and we do mean no problem, talking about this topic. In fact, Anthony Barnes has become an advocate and has talked with a lot of people about what it is like to have his prostate removed. We're also joined by his surgeon, Dr. William Parker, a urologic oncologist at the University of Kansas Cancer Center. We also have across from me, certified physician assistant Jennifer Hines, part of Anthony's care team. So thanks to all of you for being here with us. And I have to say, Dr. Parker, this all came about because I think like earlier in the year, you were like, hey, Jess, you do this thing in October where you have everything dedicated to breast cancer. We're going to do that again this year.
Yes.
But let's back it up a month. Let's go back into September. And you said, what about prostate cancer? So you're going to be sitting next to me a lot over the next month. So thank you for nudging me and bringing that to our attention. Because it is something that people don't like talking about, except this guy over here. He likes talking about it. What's it like to be sitting here between Jennifer and Dr. Parker?
Oh, it's a great thing. It's a blessing. You know, these guys, they've been good to me, you know, and they're the reason I'm still around here, able to talk and enjoy life.
Well, and share the word. So,
yes.
So you told us that before this diagnosis that you always took your health pretty seriously. We don't always hear that with guys. They get a bad rap that they're not always paying attention. Why did you feel it was so important to get those checkups and see your doctor?
Well, my brother was a juvenile diabetic growing up, so my mom changed our diet in the house. And my mother was she's a retired nurse at the time. She was still a nurse. She was working at Truman. And, you know, she would always talk about how important it is to take care of yourself, you know, because one day you're going to get old. So she would always say this. So as I became a middle-aged, well, I was probably in my early 30s, I found me a doctor, you know, and I knew that a good family friend was a family doctor at KU, Dr. Harry Lowndes, so I started going to see him, you know, and it became, you know, once a month. Getting a physical once a month. I was working at a Hallmark at the time, and they're real big on getting your annual physical. We would always get you, and that's when I really started getting my physicals, and just from that point on, you know, kept doing it.
And part of those screenings were getting your PSA checked.
Yes.
What did you learn, and you know, what did your doctor suggest you do when they started to see that number rise?
Well, Dr. Lowndes, was a little bit before he retired. He said, hey, Anthony, your PSA levels, they kind of rising. They're going up, going down. He said, we want to start keeping an eye on that. A little bit shortly after that, he retired, and Dr. Bratton, he became my main family doctor, and he noticed that I was probably about 45, I believe, you know, and then I think I started going to see Jenny, and well, it's probably about 46, 47, somewhere in that neighborhood, and he's like, hey, this thing is kind of rising. I'm going to have you go see the specialist because we want to make sure that, you know, if it is a problem, we get on this problem early.
And was this the specialist?
This was started out with her. Yes, she opened the door. Yes, Jenny opened the door, you know, and I went to go see her, and she said, you know, did all the checks and you know you do, and she said, well, Anthony, you know, your PSA numbers are high. We're not at the time. She said, well, we don't really know it was cancer, so we're not going to call it that. We think it is. She said, but here's what we're going to do. We're going to keep monitoring. So I think I was coming to see you every 6 months or something like that. And then, you know, then we kept talking. She said, well, you know what? I think we ought to get a biopsy. I'm like, okay. So, but you know what? One thing I say about Jenny is that it's like she kept it real simple, right, to where I could understand. She laid the plate out and said, hey, this is the mashed potatoes, this is the meat, this is how this works, which was good for me because I didn't know, right? So it helped me out. So here's the process we need to take in order to get here. And I think that's what really made me comfortable.
So he's really explained your role quite well, but how important is it though, once you have someone like Anthony, a patient like that engaged, that you're talking on their level and that you're helping them understand and that you're getting them to come back time after time again?
Yeah, it's really important. Anthony is great at follow-up, but you just lay all the options out and discuss the risk and benefits of each option, and then it's up to the patient to choose what they want to pursue. And thankfully, he did elect to pursue a prostate biopsy early on, and the cancer was caught early and get it addressed.
And what do you do? Anything special to help people feel comfortable talking about? I mean, you're inundated. These are the things you guys talk about all the time, but it's not always comfortable for people to hear about it and talk about it.
Yeah, just address the awkwardness. As you can say, face the elephant in the room. Just rip the Band-Aid off and talk about it. Dive right in. But make sure you sit eye level, have a conversation one-on-one, and listen to their fears too.
So you agree? You said yes. You've had to have many uncomfortable conversation.
Yes, absolutely, and it's all about just making it not awkward. Awkwardness comes from us being uncomfortable with the conversation. You just have the conversation.
I've had to fight through a lot of awkwardness on this program, talking about all sorts of things, so it's good. I get what you mean. Did you notice anything interesting when you met Anthony, just when he finally came to see you? Just what stood out with him as far as just how you were going to address his care in this case?
I mean, I think two things stood out to me. So one, Jennifer did a great job of working him up ahead of time and kind of packaging him up, if you will, and preparing him for what needed to happen. So I knew that, I had somebody that needed further evaluation. So that obviously stood out. Also, it's Anthony, so it's vibrancy for life. That's what honestly really stood out.
Yeah, you had told me, you're like, you got to meet this guy, Anthony.
Oh, yeah.
He'd be perfect to come on the show. You said kind of packaging Anthony up. I want to go back because I want to be really specific. When we hear physician's assistant and the role that you play in the care team, just give us a little more detail on that.
Yeah, so physician assistants, also known as physician associates, are licensed healthcare providers who practice medicine alongside our physician colleagues. And we, do physical exams, take histories, order lab scans, write prescriptions, sometimes even do procedures. And so we do it all alongside our physician colleagues, and I'm lucky enough to work alongside Dr. Parker.
So Dr. Parker, what were some options given to Anthony when you met him, and what was that conversation about, kind of laying the options on the table?
Well, I mean, certainly when we first met, it was at the pre-diagnosis stage. So it was really, the option was simple. We needed to know what was going on. So there was only one option. We needed to do a biopsy to figure out if there was a cancer issue or not. Now, once we made that diagnosis, then the conversation became much more complex in terms of, what are the treatments available to him, surgery, radiation, how do we need to approach this for somebody young and healthy like him?
So surgery was the option.
That's what he landed on.
That's what I chose.
And how do you come to that decision?
Well, like Dr. Parker, he gave me all the information. And what I did is I started kind of evaluate, one of my buddies, had been through leukemia and all this, so he was like, whatever you do, don't go on the internet and do all this digging. Just kind of evaluate what you think is going to work. So one thing that stood out to me is that Dr. Parker had mentioned that, the radiation, it works, but I want you to know this, is that if for some reason you do the radiation and it doesn't work, we can't go back and do surgery. It's going to be tough. I go, okay. And then after that second biopsy, I go, hey man, Dr. Parker, I like you and all. You're a great guy, but I can't be coming back to see you every 6 months for this part. So here's what we're going to do. I like it that much, right? Okay, fair enough. Hey, even though you promised to take me out for a steak dinner.
That's what you should. He got to know you pretty good.
I said, hey man, after that second biopsy, I think I called him that next week and said, hey, let's go for it. Let's get it done.
So how does that work then? You give him these options. Of course, that's your job, is to lay it out there so he's totally informed. But is it clear that there's something that's a better option for a patient? And are you steering them towards that? They're going to ask you, what do you think is best? How does that work?
It's hard. So with prostate cancer, the cure rate is the same no matter what we do. So it doesn't really matter from a cancer standpoint. So the decision making has a lot more to do with quality of life, what a patient's willing to accept as far as consequences. And they do ask often, what should I do? And it's hard when I put on my oncology hat, right? The cure rates are the same. So it doesn't really matter as long as we do something. So it's tough, and it's individualized to the person. Yeah. Everybody's decision-making process is different.
So surgery, which you chose, comes with side effects. Another awkward conversation, because I'm sure you would say, well, what are the side effects of having this surgery? And I guess it's effect on the bladder. Yeah. Let's talk about that, because you were very specific on on that process and how you got to go into the bathroom again.
Yeah, it was. So after the surgery, you have. Catheter in, and the catheter makes your bowels lazy because you're just sitting there, you're using the bathroom, you don't know you're using the bathroom. So when you go back in, you get the catheter out, but then you got to figure out, okay, well, now I go to the bathroom, well, I got to gain control back, because after a while, you just going all over the place. It's like, oh, so you say, okay, well, and as a men, we don't like to sit down and use the bathroom. We want to stand up because that's part of our machoism. So it's like, hey, look, I'm gonna have to rethink this till I get control. So it took a minute before probably a couple of weeks where I really felt, I had that control again. But still, as Dr. Parker had mentioned to me in the beginning, hey, Anthony, you're gonna have a little leakage when you chuckle, because I like to chuckle. So, so you gotta, they told me, about the pads you buy, and I believe Jenny Quinn, which is, she had said, hey, you go get these certain pads, and they gave me some after surgery. So I started using those. Well, you use the Depends first. Never thought I'd be wearing Depends, but I wore those for a minute, and then I went to the little pads. But it takes a minute, Then another thing with men too, unfortunately, we some guys, our penis is how we get going, right? It's like, this makes us macho. So it's like, okay, well, now my penis he ain't marching like he used to march. So it's like, okay, how do I work through this? But it's all, what I learned is that it's a process, it's a stage, and having guys like Dr. Parker and Jenny around, you reach out, you shoot him a text or something, or email, he'll get back to you. And he told me in the beginning, it's just gonna take a little time, And my mother, she would say, hey, you'll be all right, because first I was like, well, you know what, but being a man of God, I knew that, hey, I was still living and breathing, so everything else I could work with. So
I love that.
And I was like, hey, I'll be all right. I can work with this. And, I felt good,
Well, I'm glad you put your willingness to be healthy over your machoism.
Yeah.
And it paid off, for sure.
Definitely paid off.
Well, now you know what it's like being a woman, the sneezing and the laughing and the pain.
Yes.
So good.
Yes.
I'm glad you feel all of our pain, right, Jennifer? So
learn the Kegel, was it Kegel exercise?
Yes.
I was like, what is this?
It's a real thing. Apparently it's a thing. So on that note, sexual function.
Yeah.
How'd that go for you?
Oh man, I'm back in the game. Back in the game. I was out of the game for a minute, but I'm back in the game. And one thing we talked about is that, Dr. Parker pointed out, he goes, hey, medicine has come a long way from way back when. Because I didn't really know anybody that, well, my dad's brother had some prostate issues, but he never did talk about it. People, they have it and they never talk about it, never tell you about it. So I didn't know, And one thing Dr. Parker pointed out, he goes, hey, medicine has come a long way, and we use a robot. I was like, a robot? He goes, yeah, we use a robot. He goes, what are we going to do? We're going to do an incision here, an incision here, incision here. We're going to go in there, boop, 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 and we'll be out. I was like,
they pay him to do that. And then he's done.
And sure enough, when I look in the mirror, I saw boop, boop, boop.
That's so great.
But yeah. So
Dr. Parker, then is there, I mean, take us kind of inside the body. It makes sense that you'd have some issues down there, but what's causing that? And is there any way to, are they all inevitable? Can you limit them when you go into surgery like that?
So what's causing them is the prostate unfortunately sits at a complex anatomic location. So the urinary tract runs through the middle of it. So removing the prostate requires us to take apart the urinary tract and then put it back together again. So there's going to be a urinary consequence. The nerves that control erections are unfortunately attached to the prostate. And so to take out the prostate, we have to take those nerves and peel them off of the prostate in order to preserve future sexual function if it's appropriate. So that's what causes those issues. Now, the way we try to reduce the impact of those issues is how we do the surgery. So there are things that we can do to improve recovery of urinary control. There are things we can do to maybe safeguard erectile function in the future. But it's all based on the cancer and how, we need to meet the cancer where the cancer is. It's not meeting the quality of life. It's a cancer operation. And then we do these other things when it's appropriate to try to preserve function.
Jennifer, how important is it that these patients recover properly and they listen to doctor's orders?
I think it's really important, and we just really, appreciate how Anthony, partnered alongside us to take care of himself and, had a good recovery.
All right, let's look at what this recovery looked like at your mama's house. Here you are, sitting in the corner.
Mama's love.
Very comfy in your recliner. Tell us a little bit about the recovery process, and we talked about the side effects and how you got through those, but just in general, how was recovery?
It was interesting. It was while it was new, it gave me an opportunity, I guess, to kind of rest too. Kind of think about my health, think about where I was at in life. Crossing this bridge. I will say that, and I tell anybody this, is that when you're at a crossroad like that in your life, if you don't have any spiritual or any family support, I can really see how people commit suicide. And it's sad to say that, because you go down a rabbit hole sometimes. You go down, the why me, why this. But you have to. When I was sitting there, I was thinking about, hey, it ain't the why you, why not you, right? Mm-hmm. You're gonna tell more people about this story, so hopefully you can help somebody. So the healing process, it was just a natural. Natural. I guess you just got to take time, And I think a lot of times, especially in today's world, we don't take time. We don't take time to sit back and reflect on things. And during that process gave me really a lot of time to think about, as I said, my second half of life, right? So I sit there in that chair, and it was like, I had my buddy come over, he goes, "Oh, you got your little baby." Called my Catherine the little baby. He said, "What you gonna name it?" I said, "Man, get out of here."
Well, yeah, speaking of your friends, because you've had a lot of conversations with your friends. A lot of, nothing.
Yeah.
You did not hold back.
No.
You said to them, get to your doctor.
Yeah. So my fraternity, we have a deal. I'm on this committee called the Brothers Keeper. I'm a member of Alpha Phi Alpha. And we do my committee, which is the Brothers Keepers. Basically, you check on other brothers, see how they doing mentally, physically. You reach out to elderly brothers. So one of my deals was last year was having my fraternity brother, who's Dr. Augustus at Truman Medical Center, come in and talk about prostate cancer. And he was surprised that I reached out to him and got him to do that, but after he got done talking about it, there was a lot of brothers in the room that had questions, had conversation. So basically what it does, it starts the conversation. Because I think, to me, the biggest thing that bothered me is when I talked to Jenny, and I talked to Dr. Quinn, I talked to Dr. Parker, and hearing them say that when they tell people that they have this problem, some of them don't come back, especially black men. I'm like, what? You gotta be kidding me. But through my phase, I sit with each one of them at different times. So it's like they're always saying the same thing. I was like, wow, why is this? And it's gotta be, to me, I said, well, it's probably because they don't know. A lot of guys don't know, and they're afraid. Like I said, most men, we lead by our penis. We think that that's the machoism in us, but if you don't take care of yourself, how you plan to be around that? And that's been my deal since I went through this. Hey, I'm gonna tell anybody and everybody, I don't care who it is, about the process. And you'd be surprised. A lot of guys, they ask me, hey, how are you feeling? The first thing they ask me, how are you feeling? I'm like, hey man, it's not like a mosquito bite. You got to go to the doctor. And I ask them, do you have a doctor? And a lot of guys say, oh, I don't have a doctor. I'm like, you got to get a doctor. You got to go to the doctor. You got to go get yourself checked.
Hold your thought. I want to remind the audience, if you have questions, which I'm sure you do, use us. Contact us on the information there on your screen, YouTube or Facebook. You can email the Medical News Network as well. So I want to jump back into we talked about the racial disparity. Black men are more likely to get prostate cancer, also more likely to die from prostate cancer. A very complex issue. We could spend an entire show on this, Dr. Parker, but what do you think in general is behind that disparity?
It's tough. There are a lot of things that probably underscore why that disparity exists. I mean, one thing we know, prostate cancer is likely a genetic cancer. We don't understand all of the genetics behind prostate cancer. And so it is likely that black men are enriched in some genetic changes that increase the risk of prostate cancer. We also know, unfortunately, PSA, which is the blood test we use to screen for prostate cancer, a lot of the numbers we use were devised around white men. And so the norm values that we use are geared towards men who look like me. And we know that for black men, those numbers actually don't align. In fact, at a given PSA, the risk of prostate cancer is about twice as high for a black man as is for a white man. So if I'm using the same threshold or benchmark that I would use for me, I'm going to put somebody like Anthony at risk for being underscreened, underdiagnosed, and undertreated.
Which is a perfect segue into this is why it's important to have minorities involved in research.
Correct.
And to enroll in trials.
Exactly.
How do we get them to do things like that?
Have conversations. Be open about it. And it's taking men like Anthony who speak out about their experience to help make men feel more comfortable with the medical journey.
Jennifer, on that note, you're oftentimes the first point of contact for a patient like Anthony. How are those conversations, especially when you're talking to an African American male or anybody of a minority about their path forward?
Yeah, I think it's just having an open conversation, laying out all the options and, encouraging them to follow up, talk with their family, talk about family history, and, just make sure that they're getting good health care because access can sometimes be an issue.
Anthony, how do we, I know you're trying to fix that disparity by talking and being that voice. Any other suggestions or thoughts on how we kind of move the needle there?
Well, I think, like you said, getting more black men involved. Unfortunately, sometimes the economic piece can be an issue. But there are, I just think conversation opens the door. Starting to get guys, more attentive to their health. We all know that women tend to pay a little bit more attention to themselves than most men, and especially black men. One thing about, I'm not aching, I ain't going to the doctor. So.
And even if they are aching, sometimes they don't go to the doctor,
still
right?
don't go,
So, Dr. Parker, when should someone get screened for prostate cancer?
So the American Urological Association set some guidelines about this. So an average risk person, so that's somebody without a strong family history of prostate cancer, breast cancer, ovarian or pancreatic cancer, should start at 45 to 50. Somebody with a high risk, that would be a black man, somebody who has a family history of those cancers or who has a known genetic change, should start at 40.
Question I had, because Anthony brought it up about how some people will come in, get the information, hear about the higher PSA, hear about the risk factors, and then you never see them again. What's up with that?
I mean, I think there are a couple things behind that. So first off, men are notoriously a little bit worse about healthcare, I think. I say that as a guy, so I'm gonna knock my own self down.
Right.
It took me a long time to get a primary care physician, so I'm guilty.
Yeah, just being a doctor does not count. Sorry.
Nope. I think the other thing is, and this is the challenge with prostate cancer, and this goes to some of what Anthony was talking about the emotions surrounding this. This is a disease where I tell you you have a problem. You don't come in with a symptom, there's nothing you can feel, there's nothing that is associated with you, and I'm talking about something that the ramifications of treating, the consequences are big. We're talking about things that you take for granted. I can control my urine. I don't think about that. You take it for granted. Sexual function, you take it for granted when it's there. And so you have a disease that you don't have a symptom of, that I'm telling you you have a problem, and then consequences about things that you rely on every day.
What was it like hearing that you had cancer? Who did you turn to for support?
when they told me, I think Jenny, I think you were the first person to tell me, man, I went back, she says, well, yeah, it's cancer. I just, I leaned on my faith, growing up in a Southern Baptist household, and a mother who made you go to church if you didn't want to go to church. You learned that, I can do all things through Christ who strengthens me. So, leaned on that, and just figure, hey, Lord, I'm at this crossroad, guide me through, and that's where I was at. I think I told Jenny when we were in the room, I said, hey, okay, so I'm gonna get you with Dr. Parker. We're gonna go from there. The biopsies were rough, but no.
But you felt surrounded and loved.
I did. And I will say this too. I don't know, every doctor's bedside manner, but the doctors I've dealt with here at the KU facility, when I first met Jenny, it just felt like I had been knowing her, right? She took time with me. She didn't talk to me about my issue, filling out the clipboard, typing on the computer. She sat down in the chair and looked at me face to face. When I went to go see Dr. Parker, same thing. He wasn't fooling with the clipboard or talking to somebody else. It was him and I in the room. He looked me in the face and we had a conversation.
Another thing, you take it for granted.
Yeah.
You don't realize how much that matters until someone's staring
Until
you in
somebody's
the face.
staring you in the face, yeah. And it was just like, okay, and that was the first time I met them, and now I feel like I'm tied to them the rest of my life, so.
Right. Well, I called her Jennifer. You call her Jenny, so that's how close you two are. So, Jenny, what question do you wish more patients would ask? Anything that comes to mind?
I think just, again, hitting family history is important. Just, if you have a first-degree relative who has prostate cancer, your risk goes up. But if you have 2 first-degree relatives who have prostate cancer, that risk goes up significantly. And so, just the importance of genetic testing, and that can be really important if you have a cancer diagnosis.
Anything people should be asking?
The questions they're afraid of. I mean, I think honestly that's the piece, is there's always something somebody's afraid to ask, and I just wish they'd ask it. There's no question that's taboo.
Yeah.
I mean, we talk about the most personal things in my clinic. It doesn't really matter. Just ask it.
I think people should try to make you uncomfortable. That should be the goal, is to come and ask really weird questions that make you blush. I like that. Okay.
I've got a good poker face.
It does, I bet. All right, let's get to just a couple questions from viewers. I do have a comment. Faramond, I don't know if that's a friend of yours, but says, thank you for sharing your story, friend. So either it is a friend or somebody who'd like to be your friend because of all that you're sharing. So thank you for that. Jeremy has a question that you've kind of already answered. Is there anything that leads to that 1 in 8 number, or is it just genetics or random chance? Because it's so common, and why is it more common in black men? You touched on it, but just go over that again.
I mean, it's both. So there are genetics. So we do know that there are some men who are predisposed for prostate cancer, particularly if you have that family history of prostate cancer. Really, any cancer, you should think of yourself as being somewhat higher risk. There's also random chance. So we know that there are sporadic cancers, ones that we don't know that there's a cause of, and then there are the ones that we actually know there is some underlying change.
Sean would like to know, is a PSA test sufficient to verify prostate cancer? And that's a question. People assume it prostate with the rectal exam. So tell people, just let's get that thing out of the way. Let's just go there. So what's the difference in...
Yeah, so PSA, or prostate-specific antigen, is a blood test that we use to screen for prostate cancer. It is not sufficient to make the diagnosis. So it's the trigger to say, I think you are at risk. A biopsy is required to actually establish that diagnosis. As far as the digital rectal exam, everybody should have a digital rectal exam at the start of their screening. That's how we understand if there's a nodular growth. Unfortunately, some prostate cancers don't express a lot of PSA. Those are the ones that actually are a little bit more concerning, because they're the ones where the blood test is going to fail. And the only way to know is to actually do that rectal exam and feel. Now, if you have a normal rectal exam, the value, we know this from some evidence of repeated exams, decreases. So as long as you get one, just get the one.
Get it out of the way.
That's right.
Yeah, if you start asking for too many, that could be a problem. Okay, so Faramond also just had a comment. I'm a testicular cancer survivor, and Dr. Parker's comments around benchmarks and comparing diagnosis between white and black men are spot on. He says representation is so important. So something we really talked about. Another question Stu had, and I do too, because diet's always so important, because that's the one thing we can control. Any diet things to incorporate or leave out, or is it the same old story there?
I mean, I think there are a couple things to know. So first off, there's some weak data around three things: green tea, cruciferous vegetables, which are like broccoli, cauliflower, sprouts, and pomegranate juice, as being somewhat protective against prostate cancer. Now, don't go all in on those things. It's very,
trust
very
me,
weak
I don't think we
data.
will.
Yeah.
Like, all in on the broccoli.
Now, the most important thing, though, is as a man in the United States, the most likely thing you are to die of is not prostate cancer, it's heart disease. So what I tell everybody who's asking for dietary recommendations, heart healthy. Heart healthy is prostate healthy. So that's the biggest
all trickles
advice.
down.
Correct.
All right. This has been a great conversation. You're totally coming back on. So you're coming back.
It's been fun.
And he's been great. So what would be the big takeaway, Jenny, today from this conversation? What do you want people to know?
Yeah, I think it's just important to have a conversation with your healthcare provider about the risk and benefits of screening for prostate cancer and other types of cancer. Generally, the earlier you catch it, the more options you have and the more curable it is.
Yeah, screening is key. Anthony, what's the big takeaway from your personal story?
I think, realizing that your healthcare provider, they're people, right? They have family, they have friends, so, and they want to, help you as much as they possibly can, but you have to be willing to help yourself.
Thank you, Fred, for sharing your story.
Thank you. Appreciate it for having me.
What's the big takeaway?
Don't be afraid to ask questions. Don't be afraid to participate in your healthcare. That's the biggest thing. And don't be afraid to talk to other people about what you go through.
Great conversation. I'll see you next Tuesday, I think, right?
Yes.
Yes. Okay. Sounds great. Everyone have a great week. Thanks for being with us. Thanks to all of our viewers as well. We'll see you back here tomorrow.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.